Yes.
Yes. Okay. So thank you very much for inviting me to this meeting. So I'm going to talk about the screening diabetes food at risk for ulceration and infection. So I have more or less 15 minutes, and I had to concentrate and a brief summary about how to prevent diabetic food ulceration, and the best way to prevent infection is even to prevent ulceration. So just to show that the main etiology of diabetic food is the combination of neuropathy, peripheral arterial disease, and deformities. Probably neuropathy is the main problem, and it's starting before, and then the additional problem with deformities of peripheral arterial disease can increase the risk for development of an ulcer. But sometimes we have patients with deformities before neuropathy and peripheral arterial disease, as is something that we need to take care of, to take into account. So the most important thing of I think the positive message that we can send from here is that 80% of diabetic foot ulcer can be prevented. The question is why? Why is not so well implementing this prevention of this patient? Because the majority of the effort is putting on the acute phase, not in the prevention. So for preventing a diabetic foot ulcer, it's very important to know what is the risk factor for development. And in this case, we have general and local factor. And you can see some general factors are related with the diabetes and its comorbidities. And if you are looking for the local factor, are mainly associated with two important things. One of them is neuropathy, the other thing is deformities, and additionally, they can add another important factor like peripheral arterial disease and biomechanical disorders. Inside this slide, you can find some modifiable factor that you can change in your patient, and on the other hand, you can find some factor that is not possible to modify. So it's very important to focus in what factor is possible to modify to prevent diabetic foot ulcer. The problem is when the ulcer is developing, you have a problem because the first objective is to close the ulcer, but secondary, you can have a patient with a high risk of re-ulceration. So I used to put this example comparing this take-off process for a plane in an airport, in which there is a point of no return, in which there is nothing to do when the plane is ready to take off. And this is something that is similar in a foot patient with diabetes. So the message is please treat it to do an early identification of the foot patient, because otherwise it's very difficult to stop the development of ulceration. And the beginning is, of course, inside the comorbidities, because all these comorbidities associated with diabetes is a factor for developing ulceration. That's including metabolic control, cardiovascular disease, renal failure, and of course, depression. All factors are highly associated with the development of foot ulcer. What are coming with the international guidelines? International guidelines identify different approaches for prevention. You can see here 5 points in which they are developing what is the strategic plan for prevent diabetic foot ulcer. But the first point is identifying the at-risk foods. And how can we identify these at-risk foods? So you can mainly focusing in 3 main points: neuropathy, peripheral arterial disease, and deformities. What about the neuropathy? So you can see here the different tests or the different methods that you can do or you can make with your patient to identify diabetic neuropathy. Some of them are investigating the status of the large fibers, and some others are investigating the small fibers. It's very important to know that the first fiber that are affected by neuropathy is the smaller one, and secondly, are affecting the large fibers. But if we are going to the recommendation for the international guidelines, you can find that they are recommending to use both monofilaments, semen-wasting monofilament, or the using of the tanning fork for exploring vibration. What is the problem with this test? The problem with this test is they are exploring the large fiber, so that means that you are exploring the risk of the factor very late. So in the majority of the case, when you identify in this kind of patient, the patient has neuropathy for a long time ago. In our investigation, we demonstrate that these are around 30% of the patients. So their recommendation should be to use another kind of techniques that can identify early the neuropathy status of the patient. But the recommendation that we have included in the guideline is monofilament at turning 4. Again, I think, in my opinion, this is my personal opinion, is absolutely insufficient to identify the patient before to have a neuropathy. The problem is when you have a neuropathy, there is not a way of return to the normality, and the patient has a very high risk to develop an ulceration. Another risk factor is peripheral arterial disease. And this is another problem because there is a high misdiagnosis of this kind of patient, especially in primary care, when the people, healthcare provider, are not able to get specifically some techniques to assess this kind of patient. What is the recommendation for the international guideline? Very simple, distal pulse palpation. And this is something that is very useful, and this is something that everybody can do in any setting, and this is something that they have to do for every healthcare provider that are seeking patients with diabetes. You have to palpate the dorsal pedis and posterior tibial artery. And if the patient doesn't have any of these pulse, you have to consider as ischemic. It doesn't matter what is the level of the ischemia. This is another thing, and this is another matter that is regardless the vascular surgeon that, and in this case, this specialist has to diagnose the patient and has to decide what is the approach. But for particular point of view, it's very important to early detection in order to avoid the development of neuroischemic or ischemic ulcer. Remember that anchor brachial index, ABA doesn't have any utility in diabetic foot patients. So this is very important to remark because every day we are finding people that are making ABA for detecting peripheral arterial disease. ABA doesn't have any information concerning the status of the vascular status of the patient, especially because the majority of the patients suffer for calcification. In this study, we demonstrate that the use of the ABAs is more or less to drop a coin to the air. So that means that 50% of the patient who has normal ABA has ischemia, and 50% of the patient who has calcification coming from the ABA has ischemia. So it's better to having a lesser invasive techniques, but if you are using ABA, sometimes you can diagnose this patient. The recommendation for the international guideline is not only to use ABA isolate. They're recommending to interpret the values of the ABA associated with two tests. One of them is the assessment of the arterial waveform, and you can see if the arterial waveform is monophasis, biphasis, or triphasis, and additionally to use the toe brachial index. That means that it is not 100% accurate diagnosis of peripheral arterial disease, but of course, if you are adding this information to the ABA values, you can discover your patient. But in any case, I'm recommending the combination of those three tests and additionally the pulse palpation in order to identify early the peripheral arterial disease ischemic patient. And last but not least is the foot deformity. And probably this is one of the main gaps in the risk assessment of the patient. For every nurse in the world, for every doctor in the world, for every general practitioner in the world, for any specialty of diabetic foot in the world, is very clear neuropathy assessment and peripheral arterial or vascular assessment. But what happened with foot deformities and biomechanical assessment? In the majority of the case, is a gap. There is nobody doing, and there is something that is very associated with their high risk of developing this kind of ulceration. But the problem is, remember, deformities and biomechanical disorder are sometimes before diabetes and before neuropathy. If you are waiting a deformity after diabetes, if you are waiting a deformity after neuropathy, sometimes it's too late and the patient develops an ulceration. One important is to look up the feet of your patient to identify what kind of deformities this patient has. Remember, diabetic foot is very common in diabetes type 2. This is around, in the average of patient is around 50, 60 age, is the average of the diagnosis of this kind of diabetes. And remember, Take a look around your friends, and your relatives, and your family. Take off your shoes and look at it is possible to identify any people around you, healthy people, without any deformities in the food. What happened with the diabetes patient is absolutely the same. So probably deformity is before the diagnosis of diabetes type 2, or at least is present in around 60–70% of patients. If you are adding diabetes type 2, you are adding neuropathy, that means that is higher risk for developing an ulceration. What about callus and hyperkeratosis? There is an interesting publication coming for thinning. There are only 2 publications, and they demonstrate that callus or hyperkeratosis are more frequent in diabetes foot patients. That is not true. That is a mistake from investigation. The problem is these callus and this hyperkeratosis are bigger and are more evident because the people don't feel, the patient doesn't feel any pain. And this is the consequences, and this is the reason, because this patient is walking without any problem because they don't feel pain. Remember the GIF that Professor Bolton mentioned it before. So with this patient, we need to implement the policy of callus zero. That means any diabetes patient, any patient with diabetes in the world can allow to have a callus in his feet, because this is the main high risk factor for developing an ulceration. This is the first step. After the callus, this is an hemorrhagic hyperkeratosis, and after this hemorrhagic hyperkeratosis, this is the formation of the developed an ulceration. So if you see this patient and this patient has neuropathy, this is a question of time to develop an ulcer. So please take a look at the foot of the patient. So you know that in the United States, there are very good people for marketing, and they are doing marketing for medicine as well. And they associated the risk for mortality in a lady who palpated a palm in a breast with the same risk of mortality for a patient who has a callus in his feet. And this is true. This is not an exaggeration. This is coming from the evidence. And remember, this is very important. A callus in a patient with diabetes, and especially with neuropathy, is a very high risk factor for developing an ulceration. Of course, the majority of the ulcers are close to deformity. But what is the problem with this deformity? Probably you have in mind that the neuropathic foot or neuropathic diabetes foot, this is this kind of foot, callus foot. And there are some publications even coming from very prestigious people like Professor Bolton, that they including this callus foot associated with neuropathic foot. But what happened in the reality? When we are going to our publication, the most prevalent foot that you can find in your office is the pronated foot, the flat foot. Why? Because the deformity is not caused indeed by the neuropathy. The neuropathy is an aggravate, is a factor for a seriousness of the disease, but it's not the etiology itself. And this is very important. And more important than deformity is the limited joint mobility. So limited joint mobility is additionally a risk factor. Remember to assess the mobility, especially mobility of the ankle and mobility of the first toe that has been demonstrated that are the main factor to develop an ulceration. Of course, last but not least, the history of previous foot ulcer is the main risk factor for developing another ulcer, and especially the history of previous amputation. Especially with the amputation located in the foot, you can find different levels of amputation. First level amputation were located in the forefoot. This is associated with transverse lesion to another part of the foot. This is the transmetatarsal amputation. This is associated with the absence of the third rocker. That means that the patient has an important disorder in the gait. And finally, the last level of amputation that is associated with unstable foot, and this can cause a lesion in this leg, or in other case in the contralateral foot. And last, of course, but not least, the atypical amputation that are coming for surgeons that are addressing only the infection but never think in the foot function. Remember, you are a surgeon and you are performing foot surgery. you have to think that the food has a function. Imagine that you are a heart surgeon, and you are doing cardiac surgery, and you are not taking care about the function of the heart. It's the same. Of course, if you are doing surgery in the food, you have to take into account that the food has a function. And remember that all this combination at the end is coming for something that is additionally a risk factor for the local ulcer, the footwear. Sometimes the footwear is the beginning of everything. Footwear in a patient without sensation, with deformity, with chaos, this is another risk factor for develop an ulceration. So in summary, we can say that neuropathy associated with deformity and hyperkeratosis and insight and infarct are the main factors to develop a foot ulceration. So in conclusion, remember that diabetic foot disease is a serious complication of diabetes. That is more important. The most important factor is the development of foot ulcer. Identifying the risk food is the main strategy implementing diabetic foot ulceration. Remember, it's very important assessing neuropathy, peripheral artery disease, and foot deformities and foot function. And remember that obviously previous history of ulceral amputation are the main risk factor for developing diabetic foot ulcer. So thank you very much for your attention.